The simplest, but at the same time the most important concept is to understand the difference between leukemia and lymphoma. Leukemia is the accumulation of malignant cells in the bone marrow and blood. In contrast to this, lymphoma is the same accumulation of malignant lymphocytes, but inside the lymph nodes in tissues. Such accumulation of malignant cells in the lymph nodes cause lymph node enlargement. Do leukemias cause lymph node enlargement? The answer is yes, because cells from the blood can leak into the lymph nodes. But because malignant cells in leukemia accumulate in the blood, we can determine such accumulation of cells in complete blood count or by bone marrow aspiration. But in lymphoma, because cells accumulate inside the lymph node, the only way to see malignant cells is to perform lymph node biopsy. On this image, we can compare blood analysis in patient with B-cell non-Hodgkin lymphoma and in patient with chronic lymphocytic leukemia. In both these disorders, the signature feature is the enlargement of the lymph nodes. But as we see in lymphoma, leukocytes, including lymphocytes in the blood, are within normal margins. And in contrast to this, in chronic lymphocytic leukemia, leukocytes are significantly elevated. The reason is that malignant cells in lymphoma live and proliferate within the lymph nodes. So, until the leukemization of lymphoma happens, we will not see any changes in leukocytes in blood analysis. But in chronic lymphocytic leukemia, cells live and proliferate in the bone marrow and blood, and that's why we can see in his blood analysis such huge level of leukocytes. All lymphomas split into two buckets, Hodgkin and non-Hodgkin. We divide them based on the presence of Reed-Sternberg cells. Hodgkin lymphoma, positive for Reed-Sternberg cells. All other lymphomas that do not have Reed-Sternberg cells called non-Hodgkin lymphoma. So, as you may guess, non-Hodgkin lymphomas are far more common. If we have to compare Hodgkin lymphoma with non-Hodgkin, there are several key features. First of all, non-Hodgkin lymphoma cause enlargement of multiple lymph nodes in different body regions. Basically, person can have enlargement of lymph nodes in neck region, inguinal region, and leg region. So basically, any lymph node in our body can be affected. This pattern we call generalized lymphadenopathy. In contrast to this, Hodgkin lymphoma cause localized lymphadenopathy. What do we mean by this? In Hodgkin lymphoma, lymph nodes enlargement occurs in a contiguous pattern. Let's say, initially, subclavicular lymph nodes become affected. After this, cervical lymph nodes becomes affected. After this, mediastinal lymph nodes can be affected. But in this case, you will not see enlargement of lymph nodes in neck region and lymph nodes in the inguinal region at the same time. It's not typical for Hodgkin lymphoma. And the major difference is the presence of Reed-Sternberg cells in Hodgkin lymphoma. Here we can see these large cells that have an owl eyes appearance. Basically, if Reed-Sternberg cells are present, we call it Hodgkin lymphoma. But if Reed-Sternberg cells are absent, it's non-Hodgkin lymphoma. So obviously there are more non-Hodgkin lymphomas. In addition to this, we have to know that Hodgkin lymphomas typically cause skin symptoms as rash and pruritus. Now, within non-Hodgkin, you split again. 90% are B-cell origin, 10% are T-cell origin. Before we can understand where these lymphomas come from, we need to understand the normal lymph node architecture. Because here's the key insight. Every lymphoma originates from a specific zone of the lymph node. Know the zone and you instantly understand the lymphoma. In the lymph nodes, we can find the cortex, which is B-cell territory. The paracortex is a T-cell territory. Inside the cortex, we can find follicles, which is the signature feature of this region. On this image, we can identify every structure we just discussed. The entire follicle sits within the cortex. Below it, the paracortex, the T-cell zone, more diffuse. The lymphoid follicle, with its germinal center located in the middle, it's a pale, loosely packed area which contains actively proliferating centroblasts and centrocytes. Surrounding it is the mantle zone, a dark rim of small, resting, naive B cells packed tightly together. This is your normal baseline. Every deviation from this is pathology. Let's sharpen the focus even further on the individual follicle, because the germinal center and the mantle zone are the two microanatomical compartments that give rise to the two most important small B-cell lymphomas. On the left, a reactive normal follicle. You can see the pale germinal center, the GC, in the center. Surrounding it, the darker mantle of small naive B cells. On the right panel, we can see germinal center and mantle zone. The GC is where B cells are most active, most vulnerable to translocation errors, and this is exactly where follicular lymphoma originates. The mantle zone is where resting naive B cells sit, and this is the origin of mantle cell lymphoma. Two different zones, two completely different lymphomas, two translocations, two different clinical behaviors. And now the complete picture. One follicle, three concentric zones, three distinct lymphomas. Germinal center where follicular lymphoma originates, mantle zone that gives rise to mantle cell lymphoma, and marginal zone that gives rise to marginal zone lymphoma. We have not mentioned marginal zone because in normal condition this zone is absent. Marginal zone appears only during chronic antigen stimulation. Within the B-cell lymphomas, the key branching point is cell maturity and size. Based on this, we can divide them on small cell, intermediate cell, and large cell lymphomas. Let's begin with the small cell lymphomas. Small cell means it's a mature lymphocyte, and lymphoma from mature lymphocytes called follicular lymphoma. So here we have a list of non-Hodgkin lymphomas, specifically the neoplasms of mature B cells, because these are the ones that show up repeatedly on examinations. Each one has a signature translocation, a signature patient, and a signature buzzword that the exam loves to test. One of those lymphomas is follicular lymphoma, which is caused by a translocation between chromosome 14 and 18, which results in overexpression of BCL2 gene. So, to explain this, here we have two chromosomes, chromosome 14 up top, chromosome 18 on the bottom. Chromosome 14 carries the gene for the IgG heavy chain, and this promoter is constitutively active. It's always on, that's its job. B cells need to produce immunoglobulin constantly. Chromosome 18 carries BCL2, an anti-apoptotic protein. Under normal conditions, BCL2 is passive, kept quiet. It inhibits apoptosis only when the cell needs a survival signal. So, normally, BCL2 is off. Cells that need to die, they die. Now the translocation happens. A piece of chromosome 18 carrying BCL2 breaks off and moves onto chromosome 14 right next to that hyperactive IgG heavy chain promoter. What happens? The always-on promoter of IgG heavy chain is now driving BCL2 expression continuously, constitutively, without any break. BCL2 goes from passive to active. If BCL2 becomes active, this causes inhibition of apoptosis. So, simply speaking, the cell cannot die. This is not a story of uncontrolled proliferation. Follicular lymphoma cells are not rapidly dividing. This is a story of failed death. Cells that should undergo apoptosis simply accumulate. They pile up. The result is slow but steady increase in B lymphocytes. This is why follicular lymphoma is called indolent. It waxes and wanes, it's painless, and patients often present late with lymphadenopathy they barely noticed. So basically, this mutation makes lymphocytes a members of Davy Jones' crew. Now, let's look at what this actually looks like under the microscope, because the histology of follicular lymphoma is completely characteristic, and you need to recognize it. Look at the right panel. This is a normal lymph node. You can clearly identify the cortex, the paracortex, and importantly, where are the follicles? Only in the cortex. Organized, distinct, limited. And now look at the left panel. What do you see? Nodules, everywhere. Back-to-back follicles filling the entire lymph node. These are the neoplastic follicles. And notice something critical. Their borders are indistinct. They blur into one another. So, in follicular lymphoma, neoplastic follicles obliterate everything. Cortex, paracortex, sinuses, the entire lymph node is replaced. And at high power on the bottom left, these are small, mature-looking lymphocytes. They are not blastic, they are not rapidly cycling, they look deceptively benign. Which makes sense, this is an indolent lymphoma. The cells aren't proliferating wildly, they just can't die. Intermediate cell means it's a less mature lymphocyte. One of the intermediate cell lymphomas is mantle cell lymphoma. This lymphoma is caused by translocation between chromosomes 11 and 14, which results in overexpression of cyclin D1, which drives cellular proliferation. So, here we can see mantle cell lymphoma. It affects mostly males and is characterized by translocation between chromosomes 11 and 14. Now, let's build the mantle cell lymphoma translocation, the same way we built follicular. Here we have two chromosomes, same chromosome 14 up top, same IgG heavy chain promoter, always on, constitutively active. That part doesn't change. But chromosome 11 this time, and what's sitting on chromosome 11? Cyclin D1. And here's the critical function to understand. Cyclin D1 promotes the G1 phase to S phase transition of the cell cycle. It's the accelerator pedal. When cyclin D1 is active, the cell moves from resting into active DNA replication, into division. Under normal conditions, cyclin D1 is passive. It gets activated only when the cell receives a proper growth signal, controlled, regulated. Then translocation between chromosomes 11 and 14 happens. The cyclin D1 gene on chromosome 11 translocates onto chromosome 14, right under the always active IgG heavy chain promoter. Result, cyclin D1 is now constitutively active. The brake is gone. The cell cycle accelerator is stuck to the floor. And notice how fundamentally different this is from follicular lymphoma. In follicular, the problem was BCL2. Cells couldn't die, but they weren't proliferating rapidly either. Indolent. Here, in mantle cell, the problem is cyclin D1. Cells are actively dividing, cycling through G1 and S phase without restraint. This is why mantle cell is aggressive. It's not about survival, it's about uncontrolled proliferation. Same chromosome 14, same IgG heavy chain promoter, completely different oncogene, completely different biology. Now the histology. The first thing that hits you is that the normal follicular architecture is gone. You don't see well-defined germinal centers with pale centers. Instead, you see a diffuse or vaguely nodular proliferation of small to intermediate lymphocytes packed together throughout. Here we see mantle zone. This is where malignant cells originate. In the mantle zone located B cells that have undergone malignant transformation. And because they're proliferating aggressively due to cyclin D1 overexpression, they fill and efface the entire lymph node. Compare this to follicular lymphoma's low power. That one had back-to-back distinct neoplastic follicles. Here, much more diffuse, much more monotonous. And here is the immunohistochemical conformation. Here we see germinal center, and here is the mantle zone. This is a cyclin D1 immunostain. The brown chromogen marks cyclin D1 protein expression. Look at the distribution. The mantle zone cells are strongly and diffusely positive, dark brown nuclei throughout. The germinal center in the middle is negative, pale, unstained. This staining pattern is diagnostic. Cyclin D1 is not expressed in normal lymphoid tissue. Finding strong nuclear cyclin D1 positivity in a lymphoma is essentially pathognomonic for mantle cell lymphoma. The next lymphoma is marginal zone lymphoma. This lymphoma is caused by translocation between chromosomes 11 and 14, and the key association is H. pylori that drives MALT lymphoma. To understand the origin of marginal zone lymphoma, we have to know that the marginal zone sits on the outer edge of the follicle, and marginal zone B cells are memory B cells. They respond to antigen stimulation, and that's exactly the problem in marginal zone lymphoma. Chronic antigen stimulation drives the proliferation. Chronic inflammation creates the MALT zone. Mucosa-associated lymphoid tissue forms in places where it normally doesn't exist, like the gastric mucosa, in response to persistent H. pylori. That chronic stimulation then drives the marginal zone B cell proliferation. The most high yield point is that if you catch gastric MALT lymphoma early, before the translocation between chromosomes 11 and 14 is established, you can treat it by simply eradicating H. pylori with triple antibiotic therapy. The lymphoma regresses on its own once you remove the antigenic stimulus. This is one of the only cancers where antibiotics can be the primary treatment. That's why the exam loves this association. Same logic applies to other marginal zone associations. Sjögren's syndrome drives salivary gland MALT lymphoma, and so on. Now we add the fourth B-cell lymphoma to the diagram, and this one is in a different league entirely. Burkitt lymphoma, caused by translocation between chromosomes 8 and 14, which results in hyperactivation of c-MYC gene. And the specific feature is starry sky appearance on histological examination. Burkitt's behavior is far more aggressive than anything we've discussed so far. This is one of the fastest growing human tumors known, with a doubling time measured in hours. Burkitt hits adolescents or young adults. This is one of the youngest patient populations for any B-cell lymphoma. This lymphoma is caused by translocation between chromosomes 8 and 14, and the oncogene this time is c-MYC on chromosome 8. Same chromosome 14 IgG heavy chain promoter as in previous lymphomas, but a completely different and far more dangerous oncogene. It's same setup we've used for every translocation, and by now you should be able to predict the logic before I say it. Chromosome 14 with IgG heavy chain promoter, always on. Chromosome 8 with c-MYC, under normal conditions, passive, tightly regulated. c-MYC is a transcription factor that simultaneously does two things when active. It drives G1 to S-phase transition, pushing cells into division, and it suppresses apoptosis. Cells can't die. So one is active, one is passive. After translocation, c-MYC lands next to the constitutively active IgG heavy chain promoter on chromosome 14. It is now always on. The consequence is prolongation of G1 phase, which leads to increase in cellular proliferation, and decrease in apoptosis, which prevents cellular death. So the result is B lymphocytes that can't die and can't stop dividing. So c-MYC is actually a double hit. BCL2 was purely anti-apoptotic. Cyclin D1 was purely pro-proliferative. c-MYC is both at the same time. This is the most dangerous combination in lymphoma biology. It's why Burkitt requires the most intensive chemotherapy regimens, why it can present as an oncological emergency with tumor lysis syndrome, and why it carries a poor prognosis if not caught and treated aggressively. The unique feature of Burkitt lymphoma is starry sky appearance. Look at the left, a sea of deeply blue, densely packed cells, the night sky.
These cells are almost entirely nucleus with very little cytoplasm, and that nucleus is packed with RNA, driving relentless protein synthesis and proliferation. Scattered throughout that blue sea, pale, clear spaces, those are macrophages. Specifically, tangible body macrophages that have engulfed the debris of cells that couldn't keep up with the tumor's own explosive growth rate. Their clear cytoplasm stands out against the dark background. Those are your stars. Night sky of blue malignant lymphocytes, stars of pale macrophage cytoplasm. That's the starry sky. At image on the right, we can see stars of pale macrophage cytoplasm and night sky of blue malignant lymphocytes. That's the starry sky. This pattern is the direct histological consequence of c-Myc driving cellular proliferation. Cells are being born and dying so fast that macrophage cleanup creates this characteristic appearance. No other lymphoma looks like this. You see starry sky, you say Burkitt.
Burkitt lymphoma is associated with Epstein-Barr virus, particularly in the endemic African form, where it classically presents as a jaw lesion. The sporadic form, more common in kids in Western countries, more commonly originates in the abdomen. The next B-cell lymphoma that we have to know, called diffuse large B-cell lymphoma. It's the most common non-Hodgkin lymphoma in adults, and it's the most aggressive of the common B-cell lymphomas. Burkitt is more aggressive biologically, but diffuse large B-cell lymphoma is clinically the aggressive lymphoma you will encounter most often. Now, a high-yield connection that the exam loves to test. Both small-cell lymphoma and chronic lymphocytic leukemia can transform to diffuse large B-cell lymphoma. We call this process Richter transformation. Here's the concept. Chronic lymphocytic leukemia is a disease of mature small B lymphocytes that accumulate in the blood and bone marrow. It's indolent, slow. Patients can live with it for years. But in approximately 5 to 10% of chronic lymphocytic leukemia patients, the disease undergoes a sudden aggressive transformation. The small, mature cells acquire additional mutations and transform into large, aggressive, immature B cells. The patient who had stable chronic lymphocytic leukemia suddenly develops rapidly enlarging lymph nodes, B symptoms, and a dramatically worsening clinical picture. That transformation from chronic lymphocytic leukemia into diffuse large B-cell lymphoma is Richter transformation, and it carries a very poor prognosis because you now have an aggressive large-cell lymphoma arising in a patient whose bone marrow was already compromised by chronic lymphocytic leukemia. How diffuse large B-cell lymphoma looks on histology. On the left, we can see a normal lymph node. You can see the organized cortex, the distinct follicles, the paracortex. Architecture intact, capsule intact, everything in its place. On the right, diffuse large B-cell lymphoma. Cortex has no follicles. The follicular architecture is completely effaced. What you see instead is a diffuse infiltrate of malignant B cells that have obliterated all normal structure. These malignant B cells are breaching the lymph node capsule and infiltrating the surrounding tissue. That extracapsular extension is a feature of aggressive disease. The tumor doesn't respect normal anatomical boundaries. The word diffuse in the name is the histologic key. No nodules, no follicles, no architecture, just a sheet of large, atypical malignant B cells replacing everything. That diffuse effacement pattern distinguishes diffuse large B-cell lymphoma from follicular lymphoma, which at least maintains a nodular growth pattern even as it effaces normal zones. On this image, we can see what diffuse large B-cell lymphoma actually looks like at the cellular level. And the contrast with everything we've seen before is immediate and striking. On top, we see mitotic figure. Basically, it's a cell caught in active division. This is the histologic proof of what BCL2 and BCL6 mutations are doing molecularly.
These cells are cycling rapidly, dividing aggressively, with no restraint. Here we see large malignant B cells, and they are genuinely large. Vesicular nuclei, prominent nucleoli, abundant cytoplasm. Now look at normal lymphocytes scattered among the tumor cells. The difference in size is dramatic. The malignant cells dwarf the normal ones. So, diffuse large B-cell lymphoma usually affects older adults, caused by BCL2 and BCL6 mutations, and it's the most common lymphoma in adult population. Important to note that unlike the indolent lymphomas, diffuse large B-cell lymphoma is actually potentially curable with treatment, which makes early recognition critical. The last lymphoma we haven't discussed yet that deserves its own moment is primary central nervous system lymphoma. This lymphoma affects adults. It is EBV-related and associated with hepatitis virus and AIDS. Primary CNS lymphoma is almost exclusively a disease of severely immunocompromised patients, HIV/AIDS with a very low CD4 count, or post-transplant patients on heavy immunosuppression. It is an AIDS-defining illness. The mechanism, EBV, which in a normal immune system is kept latent and controlled, reactivates and drives B-cell proliferation directly in the CNS parenchyma in the absence of immune surveillance. Clinically, variable presentation, confusion, memory loss, seizures, focal neurological deficits. On MRI, single or multiple ring-enhancing lesions in immunocompromised patients. And here is the classic exam trap. That MRI appearance of ring-enhancing lesions in an AIDS patient looks identical to toxoplasmosis, which is far more common. That completes non-Hodgkin lymphoma. Next, we cross to the other branch of the lymphoma tree, Hodgkin lymphoma, the Reed-Sternberg cell, and why this 10% has a completely different clinical story, a different staging system, and a far better prognosis. Coming up next.